I think we have another couple of minutes, I think. Dr. Shehadad?
Fine.
So before we start, I would request all the people who have joined this webinar to put their mic at mute so that we can hear clearly and without any disturbance. Thank you for that. So I think it's time to start. It's 8 o'clock, and I would request our esteemed speaker to start the lecture. Thank you.
Thank you
and
very much.
Please put all your mics at mute.
Okay, so I will share my desktop. Okay. Okay, so let's go. So can you see the lecture?
Yes, yes.
Okay, perfect. So thank you very much for your kind invitation. My name is Iñigo Iriarte. Sorry? Okay.
Please put your mics at mute. Thank you, guys.
Okay, so I will start. Okay, so I will start my lecture. Thank you very much for your kind invitation. I'm a rehabilitationist, Iñigo Iriarte. I'm a rehabilitation specialist here in Bilbao, in the north of Spain. And I will talk about the deep gluteal syndrome. And it's focused with ultrasound and ultrasound-guided procedures. Okay? So, first of all, what is deep? I think there's someone talking over there. Okay, so what is the deep gluteal syndrome? The concept is that the deep gluteal syndrome is a pain caused by the sciatic nerve involvement in the deep gluteal space. Now this concept has evolved. Someone is talking over there. I cannot hear myself.
Sorry, guys. Can you please mute your mics? Hi, everybody. Can you please mute your mic? Thank you.
Okay, let's continue. This is a pain. No, don't worry, no problem at all. It's a pain syndrome caused by the sciatic nerve involvement at the deep gluteal space. Now this concept has evolved a lot because now we can talk about the deep gluteal syndrome without the involvement of the sciatic nerve itself. So first of all, we are going to take a look at what is the deep gluteal space. The deep gluteal space is the space located deep to the gluteus maximus and superficial to the acetabulum, joint capsule, and femur. Its boundaries is medial to the linea aspera and greater tuberosity, is lateral to the sacrotuberous ligament and the minor and major sciatic foramina, is inferior to the upper margin of the greater sciatic notch, and is superior to the ischial tuberosity at the origin of the hamstrings. So this space has several structures inside that are important to know. First of all, the muscles. In terms of muscles, from up to down, we will find the piriformis muscle. We will find the superior gemellus, the obturator internus, and the inferior gemellus. If we continue, we will find the quadratus femoris, and finally, the origin of the hamstrings. So those are the muscles, but there is other structures. Of course, the sciatic nerve, which is the king of this deep gluteal space, But there are several other vessels and nerves that we must know, as for example, the superior and inferior gluteal nerves, the posterior femorocutaneous nerve, pudendal nerve, and the inferior gluteal arteries and veins. So all these structures are located in the deep gluteal space. Which are the symptoms of the deep gluteal syndrome? The symptoms are usually difficult, non-specific. There is not an acute sharp pain usually, but a progressive onset of pain, a deep pain in the gluteal area. So usually there is a combination of several symptoms. Of course, gluteal pain is the main one, usually located posterior trochanteric, or sometimes with sciatic irradiation. Usually it's unilateral, but sometimes it may be bilateral. Usually the patient may complain of non-specific sensory disturbances, and lumbar pain is usually very common, but it's not, lumbar pain is not the cause of this gluteal syndrome, but it's usually associated, that may increase the difficulty of the diagnosis. It's very characteristic the intolerance to prolonged sitting, and the patient usually use antialgic positions during prolonged sitting, like this you can see in the picture. It's very characteristic. The pain at deep gluteal area with the palpation is also useful to suspect this deep gluteal syndrome. And in the differential diagnosis, we can take a look at the lumbar vertebrae, because usually can irradiate to the buttocks, hip, the posterior hip, sacroiliac joint, the greater trochanter, or even functional pain, of course, as you can imagine. As I told you before, there are several entities that can produce this gluteal pain, this deep gluteal pain. Usually, the first one known is the piriform syndrome, but there are others, like, for example, the gemally obturator syndrome, the ischiofemoral impingement, hamstring tendinopathies, or fibrovascular bands, and all of these clinical entities may produce neuritis of the sciatic nerve, neuritis. So even if you don't have the sciatic component of pain, this neuritis, you will have pain caused by these structures, and all structures, these clinical entities, belong to the deep gluteal syndrome. First of all, the piriform syndrome. The piriform syndrome might be caused because piriformis hypertrophy, that you can see here. We usually use the MRI is the main image technique to diagnose the deep gluteal syndrome, because it's more sensitive and more sensible than ultrasound or other techniques. Okay, usually if you find this hyperintensity of the sciatic nerve in T2 or DP fat SAT sequences, you may suspect a neuritis. In this case, you can see this hypertrophy of the piriformis with this neuritis of the sciatic nerve. This is another example of this hypertrophy of the left piriformis. And as you can see here, just here, this small hyperintensity of the sciatic nerve, if we compare, especially here, if we compare one side to another. There are some anatomical variants that may help provoking this deep gluteal syndrome, but it's not the cause itself. It may have, it might be related, but usually you can find these anatomical variations without pathology. But we need to know this classification usually uses the Beaton and Anson classification. The A type is the most common by far, 83% of the cases, and you will find the sciatic nerve as a unique trunk, a unique nerve, deep to the piriformis. It becomes extrapelvic deep to the piriformis muscle. The B type is that the sciatic nerve has two components, separated components, the peroneal component and the tibial component. The peroneal component goes through the piriformis muscle, and the tibial component goes underneath, deep to the piriformis muscle. This is the B type with almost 14% of the cases. The C type is that the peroneal component is superficial to the piriformis, and the tibial component is deep to the piriformis. So if we take a look at the A, B, and C types, they will be 97% of all the cases. So if we know these three types, we could know almost all the variants we will find. There are others, like, for example, the sciatic nerve going through the piriformis, this is the D type, the E type with the tibial component through the piriformis and the peroneal component superficial to the piriformis, and others, okay? But I want you to remember that the A type is under the piriformis. This one is the most important. The B type with the peroneal component through the piriformis, and the C type with the peroneal component superficial to the piriformis. Just remember these three types that are the most important. Of course, we can use the MRI to diagnose these variabilities. In this case, you will find here you can see the tibial component underneath the piriformis. You can see here the piriformis, and you will see how the sciatic nerve divides into two components, and the peroneal component goes through the piriformis while the tibial component goes underneath the piriformis. So this is the B type. We can see this B type with ultrasound too, and you can see here. This is the piriformis. You can see the peroneal component through the piriformis and the tibial component underneath. This is the C component, the C type, sorry. And you can see here, oops, sorry. Here you can see the tibial component underneath the piriformis and the peroneal component superficial. So this is the C type. Very important to know these types just before perform any procedure, okay? And with ultrasound, this is the C type, and you see here the piriformis, and you see the peroneal component over the piriformis and the tibial underneath, okay? This is the peroneal component, this is the tibial component, and this is the piriformis. So this is the C type. To diagnose the piriformis syndrome, of course, we have the symptoms. We have just met the symptoms, and some clinical tests may help to this diagnosis. First of all, the straight leg raising test to test the component of the sciatic nerve, okay, the neuritis of the sciatic nerve. Then we have the Freiberg sign with this internal rotation with extension of the hip. If the patient feels pain at the buttock area, we may suspect some pain at the piriformis origin. This is a pace test. Then we ask the patient to push against our hands in abduction of the hip, okay? And again, pain in the buttock will make us suspect that the piriformis is involved. The fair test with this flexion, adduction, and internal rotation of the hip. We are performing a stretch of the piriformis, and again, pain in the posterior side is indicator of piriformis involvement. But the two most commonly used is the seated piriformis stretch test. So we place our finger in the greater sciatic notch, extend the knee, internal rotation of the hip, and adduction. And again, pain in this posterior side, in the greater sciatic notch, make us suspect that is an involvement of the piriformis. And the final one is the active piriformis test with this, again, lateral decubitus. In this case, we palpate again the greater sciatic notch and ask the patient to perform an external rotation, resisted external rotation, and again, pain at this level makes us suspect that the piriformis is involved. Next clinical entity is the gemelli obturator syndrome. That is uncommon, and it's not because of an anatomic problem, but because of a dynamic entrapment and dislocation. Usually is a scissor-like effect with the piriformis and the gemina and the obturator internus. Yeah, in MRI, we can see this hyperintensity of the sciatic nerve just underneath inferior to the greater foramen, and we must compare with the contralateral side. Always check the DP FATSAT or the T2 sequences and the T1 in searching the loss of this fascicular pattern. Ultrasound may be helpful. In this case, this is a colleague that suffered pain in the buttock area. I performed this ultrasound scan, and I found the sciatic nerve swollen here, and we suspected in the clinical diagnosis of deep gluteal syndrome. We perform a comparison with the other side, and you can see here the sciatic nerve in the healthy side, and the sciatic nerve swollen, hypoechoic, and with loss of this fascicular pattern in the affected side. So in this case, we perform this CT-guided hydrodissection, and the patient felt relieved. Again, another case, here you can see in this coronal view, the sciatic nerve, hyperechoic, comparing with the contralateral side, okay, at this level. About ischiofemoral impingement is the next clinical entity, space caused by a narrow space between the ischial tuberosity and the lesser tuberosity. So between this lesser tuberosity and the ischial tuberosity and the origin of the hamstrings, this is a narrow space that in some cases is narrower and may produce problems with the quadratus femoris at this level, with edema or atrophy, and of course, irritation of the sciatic nerve. Coxa valga is a predisposing factor. Again, the symptoms is deep gluteal pain, and usually there are two clinical maneuvers we may know. That is the ischiofemoral impingement test and the long stride walk. The first one is an extension with adduction, extension of the hip with adduction that provokes pain. And if we repeat the maneuver with abduction, we open this space and there's no pain anymore. So with extension and adduction, pain, and with extension but abduction, no pain. So this is the ischiofemoral impingement test. And the long straight walk is pain in this phase of the walk, okay? Because of the, again, reproducing the impingement at the posterior level. In MRI, we can see in this case an atrophy of the quadratus femoris at the ischiofemoral space, okay, and the narrow space we can find here. Some papers tell us about measures of how to measure this space, but usually there's no good correlation between measures and pathology, because some are narrow but without pathology. It depends on the rotation of the hip, so it's very difficult to see and to say that space less than, I don't know, 2 centimeters is pathologic or not. So I always perform this MRI, see if there is edema in the quadratus femoris, atrophy, and of course, if there is symptoms correlated with this possibility. About hamstrings, insertional tendinopathies are quite common, okay? Usually, the patient will complain about pain at the ischial tuberosity. Of course, the pain worsens, increases with sports and prolonged sitting, okay? And sometimes, because of the proximity of the sciatic nerve, some symptoms of neuritis can be added to this clinical entity. In this MRI, you can see the common tendon of the biceps femoris and semitendinosus with this small tear, and the tendon of the semifemoral osseous with this tear here. You can see here, okay? So this affection of the hamstrings. You can see another example here with this important affection with swelling and even bony edema, and the proximity of the sciatic nerve that may be involved when there is inflammation. In ultrasound, you can see here this huge thickening of the origin of the hamstrings, and even this small hypoechoic, this is the same mrinal osseous, this is the common tendon, Here you can see this small tear inside the semimembranosus, and with this important affection and the proximity of the sciatic nerve. Fibrovascular bands are now discussed because that is very difficult with MRI or other image techniques to be sure that these bands are the cause of the problem. No? Usually, these bands have been described in a macroscopic point of view as fibrovascular, fibrous, or vascular, as regarding the pathogenic mechanism as compression, like these bands or type 1, with adhesive bands or type 2, or complex bands or type 3 surrounding the sciatic nerve. In terms of location, proximal, distal, or middle. You can see here an example of a band compressing the sciatic nerve at this level. And treatments, of course, we must treat first in a conservative way using physiotherapy, stretching, physiotherapy of the low back, but this is not the purpose of this lecture. I'm going to talk about ultrasound-guided procedures. About evidence in the hydroresection of the sciatic nerve, there's no scientific evidence of its effectivity. That's why we never should use these techniques as the first attempt. So these techniques are only indicated when the exercises and physiotherapy doesn't work. To surround the nerve is ideal, but not mandatory. So don't be too aggressive treating to surround the nerve, because the nerve is surrounded by some veins, and you may attempt to be intravascular. So your main purpose is to be effective. So no, it's not so important to surround the nerve. Volumes between 5 cc's and 20 cc's are enough, okay, to achieve a good block of the nerve. 16% of the injections are intraneural, despite no clinical warnings. So be careful with the injection at this level. But despite being intraneural, complications are rare. Okay, so it's not so big to be intraneural, but if you can't be outside the nerve, it's better. We can perform several types of injections in this deep gluteal syndrome. The most commonly used are piriformis injection, quadratus femoris injection, hamstrings injection, and finally, hydrodissection of the sciatic nerve. To locate the deep gluteal space with ultrasound is quite easy. Of course, it depends on the patient, or the morphology of the patient, but usually if we use, this is a linear probe, but usually I use convex probe, okay? First of all, we need to locate the bone, the posterior superior iliac spine, okay? And in short axis, and you will see the iliac bone here, okay? Like an abysm, okay? So this is the first image we need to locate. Then we will rotate the probe 15 degrees, okay? And this image I want you to show you is this iliac spine. So now you know exactly where are we, okay? Then we will turn the probe 15 degrees because it's the orientation of the piriformis muscle. And we will go down inferiorly until we see the greater foramen, okay? So we will see the interruption of this cortical, of this cortex here, and the whole will contain the piriformis muscle. So this is the hole, this interruption of the cortex, and this will be the piriformis muscle underneath the gluteus maximus. This piriformis usually has an acoustic reinforcement just below, underneath, that will be the sciatic nerve. If we follow the sciatic nerve in short axis, we will see the gemelli obturator complex. And you will see how the sciatic nerve comes from inferior and difficult to see to more superficial and very easy to see above a muscle. So this muscle should be or one of the gemellus or gemelli, sorry, or the obturator internus. But here we can have a very good view of the sciatic nerve. Another example, in this case, we have a very good view of the obturator internus obturator internus, obturator internus tendon. Yes, and this is the sciatic nerve, and you can see the obturator internus tendon. If we continue more distal, we will be located at the ischiofemoral space. You can see here the ischial tuberosity. This is the posterior side of the rotator trochanter. And you can see here the quadratus femoris, gluteus maximus, and again, the sciatic nerve. This will be the origin of the hamstrings. If we turn the probe over the sciatic nerve, we will see how it becomes from intrapelvic to extrapelvic, underneath the piriformis, and above the superior gemellus and the obturator internus. We can follow the nerve distally, and we have the tendon of the obturator internus at this level. So as you can see, the gluteal and the deep gluteal space is quite easy to find with ultrasound. So first of all, the injection of the piriformis. We go from lateral to medial. I usually use these extension sets to be sure not to move once we are located inside the structure, okay? So we continue until we reach the piriformis muscle. Always take a look at the sciatic nerve. This is the A variant. There is no sciatic nerve over there. And we perform the injection inside the piriformis. I have no experience with botulinum toxin. Okay, I usually use corticosteroids. Okay, I usually go to 1 or 2 different points inside the muscle. I usually finish with a fascial dissection, the plane between the gluteus maximus and the piriformis. This is an example, a B variant of the nerve, and always we need to have in mind this possibility. This is the peroneal component, this is the tibial component. You can see here the peroneal component and the tibial component. So be careful, avoid this area here and go to this other area here to be sure we are not damaging the nerve. That's it. Now with the ischiofemoral impingement syndrome. Oops, sorry. Okay. So in this case, it's very important when you have a very narrow ischiofemoral space, okay? You can see it's difficult it's difficult to go there to the quadratus femoris in this position. Then you can ask the patient to perform an internal rotation of the hip, and then the space widens and you can go over there, okay, without danger to touch the sciatic nerve. You can see external rotation and internal rotation and how the space widens, okay? Again, from lateral to medial. This is a microconvex probe that I usually use. This is a pediatric probe because we have a good balance between definition, between resolution and depth. Always check not to be too close to the sciatic nerve. And then we continue until we reach here the quadratus femoris. In this case, I don't usually use anesthetics because if we use anesthetics, we can perform a block of the sciatic nerve. In case we don't want to perform this block because we are sure we are in ischiofemoral impingement, don't use anesthetics, but saline solution, okay? And we will avoid blockades of the nerve with corticosteroids, of course. The hamstrings injection. In this case, this is a rupture, a tear inside the semimembranosus. This is a PRP injection. Again, always check for the sciatic nerve. And this artery you can see here. The tear was located over there. We have a better view of this tear with the MRI, but we know that it's located here. So in this case, we are going to locate the needle inside the semimembranosus. Must be careful. You will see the needle just right now. Okay, never inject inside the tendon with resistance. Okay, always try to not perform a resisted injection, intratendinous injection. Now we are located here. And you will see how the PRP spreads without problem once we are located here, once we are located inside the tear. There's no resistance here. And the PRP shows that the tear inside, and you can see even how the hamstrings are not stuck, are separated for the skeletal velocity because there is a tear over there. And what about sciatic aortic dissection? As I told you, I usually use these microconvex probes. In some cases, it's impossible to perform this technique because ultrasound does not give us a reliable image. So in this case, it's not possible to perform this technique with ultrasound with safety, of course, with efficacy. So in these cases, we must not try to perform this technique with ultrasound. I usually use a 22G spinal needle. Usually, I prefer 90 millimeters length, just in case we need it. We can go with 10 centimeters or 20 centimeters syringes, but as I told you before, with 5 to 20 cc's is enough. So I usually use this 10 cc's, and I use a full this syringe with 12 cc's is enough. I always use an extension set to be sure not to move once we are beginning to inject. We can usually use chansinolone, betamethasone, even dexamethasone. So there's no paper showing which one is the best. And about the anesthetics, we can use a long-lasting anesthetic or even a saline solution when we don't want the effect of the anesthetic block. Volumes between 5 and 20 centimeters, I use 12 cc's, and it's enough for me to achieve a good hydrodissection. Paresthesias or paresias in the sciatic territory may occur, they are not so frequent. Infection is very rare. Post-traumatic neuritis may occur, but again, it's not very frequent. And intravascular injection must be aware, and that's why I use these extension sets and try to be sure not to be inside the vessel. I place the patient in prone decubitus usually. Lateral decubitus is described, but I prefer prone decubitus. It's more comfortable for the patient and for me. I usually use iodine to clean the area, and I usually use probe covers, sterile probe covers always. I perform an anatomical evaluation of the area, first of all, to be sure that there are not variants of the sciatic nerve, and locate all the structures and see the echogenicity and the quality of the image. And I usually use this lateral to medial approach. For me, is the best by far to have a good hydrodissection, but also is described this out of plane possibility. I always try to go in plane because for me it's safer and more specific. So you can perform the injection at this level. This is the ischiofemoral space with the quadratus femoris, and the injection surrounding the sciatic nerve at this level has been described. But I usually prefer to go slightly more proximal, more cranial, more cephalad, because I have the bone of the bone here, so I can go with the probe, with the needle, touch the bone to be sure that we are have a good location, a proper location, and perform the injection. So this is the example. You see, I have a good view of the sciatic nerve from lateral to medial, always using this extension set. We must be careful when we are reaching this space here. Once we think we are located at the side of the sciatic nerve, we will try to see how the injectate spreads. As you can see, we're very close to the sciatic nerve. Sorry, here. And now we are going to check. It's not bad, but still not the better image. So I will adjust a little bit the needle in order to have a clean view of the injectate over surrounding the nerve. Now, this image is better. I think that we have a good spread of the injectate at this level. We try to surround the nerve, but I think it's not so important. So I go slightly more here. You can see how the injectate is surrounding the sciatic nerve. Be careful at this area. Be patient. This is not, sorry, this is not a painful technique. The patient feels quite well. And once we have performed the injection, we always check, and you will see how the nerve is surrounded by the injectate, okay? So this is a good hydroresection of the nerve and in long axis. So important tips on deep gluteal syndrome. The image with MRI is mandatory, but not enough. We don't perform diagnosis of deep gluteal syndrome using only image. This is very important. We have a lot of false positives or false, well, not so much, but false positives, yes, are very frequent. So MRI is mandatory, but not enough. Clinical assessment is always needed, always. It's important to rule other pathologies, especially low back pain and pain irradiated from the lumbar area, and functional, very important too. Injections are useful to confirm and to treat. So if you have a good diagnosis of a clear deep gluteal syndrome caused by a neuritis of the sciatic nerve, then injections are very useful, okay? So be sure to have a good diagnosis, and you can use these techniques. So the word most important in this lecture is diagnosis, especially clinical one, okay? And then use the MRI to be sure to confirm and to direct your techniques. Thank you very much.
Thank you. Thank you, Dr. Iñigo. This was really an excellent presentation. And this condition is, as you have already told, it's a very frequently misdiagnosed condition. So we need to exclude all other tendinopathy, sciatic entrapment, or ischiofemoral impingement, everything. And in India also, we are doing a lot of work on the diagnostic part other than the intervention part. And so it's really, you have elaborated everything so beautifully, and youngster who have really loved to see the interventions, would like to do the interventions, you have elaborated in a very simple and fantastic manner. And we can see if we have questions in chat box also. And the first question is, do you proceed with piriformis injection based on clinical examination, or do you always confirm with MRI looking for the piriformis hypertrophy and sciatic edema?
It depends. If I have a very clear, for example, hamstring tendinopathy, and I don't suspect anything else, there's no need for me to use MRI in these cases, okay? But usually when you have this deep pain, there is not so clear if there is a unique pathology. So they're usually long-lasting cases with that are months and months with pain. So in these cases, I always perform an MRI. And in the MRI protocol, there is always a sequence of the lumbar spine, okay? Because we need to rule out, for example, herniated discs, affection of the roots. We need a comprehensive approach to this long-lasting pain. No? So in these cases, I always perform MRI. Mm-hmm.
Yes, great. And other like Mrinal sir, do you have any other experiences related to this question, sir? Would you like to answer or speak something about this question?
We have a couple of patients where we have done botulinum toxin for piriformis syndrome. And in fact, we had a patient, I think the beaten classification G, if I'm correct, and I can remember correctly if I'm true, and where we had a split piriformis with a split sciatic nerve. And I think we published that anatomical variations also. So I think this classification that he has described is very important. And all the anatomy videos that he has shown, they are just so wonderful. So I truly agree with him. And I think at this point, it is also important that beaten classification should be in your mind while you're doing that.
Yes.
That's great. Dr. Shehadad,
yes,
do you
of
have
course,
any other experience?
Sometimes, excuse me, sometimes ultrasound images are not so good because of the echogenicity of the patient. No, sometimes, and it also depends on the machine. But sometimes we suffer. First time I began with these techniques, I have another machine, and I suffered a lot, because you were not sure where you were with the needle. So once I had a better machine, and this fantastic probe, this microconvex probe, this pediatric probe, the thing changed a lot. Now, except in some cases, I feel very confident with the technique. Okay, so there are some cases not, but usually in the 90% of the cases, 80% of the cases, I feel very, very confident to place the needle exactly where I want.
That is true, actually, because the older probe that we have with the TurboMax, it was not that much penetrating deep. But now that we're using that spinal probe, we're able to actually see. Recently, we did a phenol block for sciatic nerve in the ischiofemoral tunnel. So I think, as you said, the probe really matters sometimes.
Yes, very good. And another question we have, why do you choose lateral to medial for piriformis? Usually do medial to lateral. This is the way I was taught. Some iPhone user is asking this question.
Yes, you can use both, of course. But usually, when medial to lateral, the position of the probe, usually you need to go very perpendicular to the skin with the needle, and in the other position you go very I don't know the name in English, tangential. So the angle of the needle is more comfortable for me. And you can use both, but usually I prefer from lateral to medial. You are seated very comfortable, and you have a good view of the needle. Okay, and you don't have the sacrum giving you some being more uncomfortable. No, so I always prefer this one.
That is true, because you always try to go ergonomically in a better way, where you are actually pushing the needle away from you. And doing it the other way would always be a bit difficult. But yes. Anyway, a person can do whatever is the best way for the patient and for himself. Yeah.
take into account that the piriformis muscle goes from superficial to more deep, no? So deeper, sorry. So the angle of the needle from medial to lateral for me is more difficult to practice.
Yeah, really, you can say it's a personal preference also. Both way can be injected, but really, like I also find it easy to go via lateral to medial. And we have another question, like how frequently do we inject this area, and which do you prefer, lidocaine or bupivacaine?
I usually, when I use an anesthetic, I usually use bupivacaine because it's a long-lasting anesthetic, no? So usually in blocks, when you perform a block, I prefer this kind of anesthetics. How many times? It depends on the results after the first one. Usually in chronic cases, it's usually not common to need several procedures, and I usually wait 2 or 3 weeks from the first one to check if there is an improvement, and when there is improvement, I perform the second one, usually 3 weeks after the first one. But there's not there is not science beneath this indication. Okay, so I try to use common sense, and it's very important to check. The advantage of the anesthetics is the block. If the patient feels a relief of pain just after the block, you are sure you are at the correct area, and that's why I use this blockade. No, if I don't want this effect, I don't use anesthetic. I use saline solution because I want the effect of the steroid, of the anti-inflammatory drug, but not the block, because if you block the sciatic nerve, it's not agreeable for the patient. No, they cannot walk. So there's no need. I don't use. And 2 or 3 weeks, more or less. 2 is a partial relief. 2 or maybe 3. If you don't succeed with 3 procedures, I usually don't perform more.
Yes. And also the type of injective that is being used. Like sometimes people try to use a steroid. So I think a cumulative dose of steroid, we should not inject more than 3 probably in a year, because there is now this recent study that I was reviewing where there is significant suppression of the adrenocorticotropic pathway by multiple. Like if you inject 3 injections of the Dept, then the cumulative dose is 2050 grams, which is pretty high. So as you rightly said, it depends what you're actually injecting.
Yes. And another question is MRI plus MR neurography superior to MRI alone for the assessment of piriformis entrapment?
Of course, neurography is superior, but it's not so easy to find MRI machines with these complementary techniques. No, neurography is superior because it's a functional evaluation of the nerve. Okay, of course.
Yes. Yeah, and it is sometimes difficult. But what the paper that we published, as I was indicating earlier, we actually used the Evion capsule, and we taped it with the glutea and tried to use our usual MRI machine to actually see the position. So those tricks sometimes we have to play, and it's very costly also. The MR neurography is pretty costly.
In my experience, you usually must manage with not so clear imaging diagnosis. You must be more confident with the history of the patient, with your clinical exploration, and with a subtle, sometimes neuritis in the MRI, or even normal MRIs. No, sometimes you must manage this. The real patient is different. It's not so easy, no, there's a clear neuritis. Now we are going to perform this block. Sometimes you rule out other pathologies. You rule out a functional problem, and you have a patient with pain. And because it's a safe procedure, in this case, I use the block with anesthetics, and see what happens, no, in these cases. So if the patient gets relief, then I will go with the corticosteroid without fear, because I have no severe complications in these cases. So sometimes you need to do something with the patients. No?
The other problem, as you rightly said, that the images that is actually received by the clinician, they are like couple of slices of the MR scans. And it's the radiologist who is sitting at the console. We have to sometimes believe him, because what you get is probably a small area. If you leave that in a section, you probably won't see in the printed images.
Mm-hmm.
Yes. And another question is, what is the mechanism of action of corticosteroid in nerve block, like sciatic nerve? Because we get clinical improvement more than 6 weeks, and how its duration of action prolonged for 6 weeks to 12 weeks.
It's very discussed, this the mechanism of action. I usually think about it as some kind of compression or dynamic compression of the nerve. Some, I don't know, scar tissue, something like that, and you can atrophy this scar tissue and release this pressure over the sciatic nerve. It's very clear in the case, for example, hamstrings pathology. No, there is sometimes swelling surrounding, not inside the tendon, but surrounding the tendon. I don't know. It's the same for the carpal tunnel syndrome. It's the same for other entrapments. No, you cannot see the entrapment with the image techniques usually when it's not a very severe one. Okay, but there is some effect of the corticosteroid releasing this potential compression.
Yes.
One of the things that I would like to add is that there is no clear actually pharmacokinetic pathway that we have come to know why the steroid actually prolongs the action. But as the professor has rightly pointed out, that if there is an inflammatory component, it really works well. But how actually it prolongs the effect of anesthesia, we still have to learn that.
Yes. Yes, I think in the on it, especially when you have neuritis, no, there's some swollen.
Yes.
So, but of course, the prolongation of the effect of the anesthetics, I don't know.
Yeah, nobody knows actually.
Yeah.
Dr. Aradhana is asking, please highlight the importance of diagnostic block in these cases. Should it be a routine in absence of MRI feasibility?
I don't understand the question. What is the question?
Question is, please highlight the importance. Sorry? Please highlight the importance of diagnostic block in these cases. Should it be a routine in absence of MRI feasibility?
Okay. For me, yes, but I want to highlight how important it is to have this interview with the patient. When a patient is telling you when you not suspect a functional part in the pain, no, this is very important, because when the patient tells you pain with prolonged sitting, with this and these activities in an active patient with no other problems, then of course I try this blockade to help in the diagnosis and to treat the patient, of course. But always check for other possibilities. Be sure that it's not low back problems. Be sure that it's not, I don't know, compensatory gains, other work issues. I don't know. Try to dig in these aspects, because sometimes we will try to help the patient, but we are not going to be successful in these cases.
Yes. And Dr. Sanjeev is asking, do you have any experience with posterior buttock thigh pain and posterior cutaneous nerve of thigh intervention?
Taping. Posterior buttock tape.
Posterior buttock or posterior thigh pain, yeah.
Like the pain secondary to the posterior cutaneous femoral now.
No. No, I not especially. I sometimes, if I suspect a femorocutaneous nerve affection, I will block in this in the space I show you just before. No, in the ischiofemoral space, you will see the quadratus femoris, and you will see the sciatic nerve underneath the gluteus maximus. And at this level, you can perform a block in this fascial space between both muscles. And this is where is located the posterior femoral cutaneous nerve. But I don't have really vast experience in these cases because I don't have too many cases of this suspicion of posterior femoral cutaneous nerve entrapment. Usually, I suspect more a radiated pain from the back pain. No? So, don't have a lot of experience in these cases. Sorry.
And another question is piriformis syndrome same or is different from the deep gluteal syndrome? It has already been answered. Piriformis syndrome is a part of deep gluteal syndrome.
It's part of it. Yes. Yes. It's not. There's no more piriformis syndrome. It's inside this new concept of gluteal syndrome.
Yes. And one question is, which will be more comfortable position for sciatic nerve block, prone or lateral lying position? As Nysora mentioned, lateral lying position with hip flexed will be more comfortable.
I started with this prone position. The patient is comfortable. I manage very well because I have the sciatic spine, the bone, so I touch. I feel very comfortable with this position. So I didn't try to change. So that's why. But of course, if you feel comfortable in lateral decubitus, it's described as another possibility. For me, it's very easy to perform. Not very easy, but I'm very used to this position. So I don't want to try anything else.
Yeah. Thank you. There is a lot of messages like, thank you, sir. Thank you, sir. Great presentation. Very informative session. Excellent presentation and all. I think this session is really like, it has been eye-opener for like beginners, especially PGs. So that I think it's very important. First is diagnostic part. We should diagnose properly. So in this case, in musculoskeletal medicine, this musculoskeletal ultrasound is playing a great role, especially in this case, especially like greater trochanter pain syndrome or subgluteal pain syndrome. This is very important. Musculoskeletal medicine it's really like a stethoscope. Every time we have to like assess clinically, and we have to extend our clinical examination through ultrasound. And this was really very beautiful presentation. And I will like to some comments from Dr. Shehadad as well.
Yeah, definitely, it was a very nice presentation, and
thank you.
The attendance was also very good. It was near 100, I think almost 99 and 100. And I will request all the participants to visit Dr. Iñigo Iriarte's YouTube channel, MskFreak, where you will find excellent educational videos on musculoskeletal ultrasound. All this, actually, the sciatic nerve imaging, all are described in that YouTube channel. So it will be very helpful to you. So I usually advise my students to just check these YouTube videos and then perform on the patient, then reach it. So the anatomy is given there, then that standing technique is given there, the good images. And as actually he have shown in the presentation, the comparison with the MRI, everything is given there. So it's a very excellent educational tool. So I request all of you to note that the name of the channel, MskFreak, and there is the website also. Now I think the textbook also is there. So you make maximum use of the educational materials, excellent educational materials by Dr. Iñigo Iriarte. So thank you very much, Dr. Iñigo Iriarte. It's a very excellent presentation.
Thank you very much. Thank you very much. I really appreciate it.
Yeah, thank you.
So,
it was great having you here, and the anatomy was so wonderful and so intricately explained. Thank you for that.
Yes, a little advice to young colleagues that are starting with ultrasound. Don't forget not to change your clinical skills to the ultrasound. Clinical skills are the most important by far. To listen to the patient, to ask the patient, to explore the patient clinically, and then after that, perform the ultrasound. So don't forget that, because there are so many false positives or false negatives, especially false positives in ultrasound or in MRI, that makes the rehabilitation specialist a very important specialist in MSK is its expertise in the clinical examination. That's key. Don't forget that, and don't be attracted by the ultrasound guided procedures. You don't have a good diagnosis. Ultrasound guided procedures don't work. So this is very, very important. Never forget that. Okay.
Yes.
And also the chronic pain patients who have those pains like
Of
from
course,
last couple of
course.
years. And my old boss, Dr. Dilip Kapoor, he used to say, if you inject in a long-standing chronic pain patient, you inject him and you get married to him.
Very wise.
No, main thing is when you don't do the clinical examination, I will apply your ultrasound. You will get lot of pathologies which are really not causing any pain. Because like with my experience, I will see there are a lot of shoulder tear, tendinitis, even bursitis that are totally non-painful. Because in my practice, I did a lot of like my 60% patient are of inflammatory arthritis age group. So really, I have got a great experience which things are normal, which things are not normal. But first you have to clinically assess, then you have to clinically correlate. Don't jump and put the ultrasound probe onto the patient. That is my last message to all the audience.
Okay.
Thank you.
Thank you.
A wonderful evening we had. Wonderful evening.
Nice.
Thank you.
Okay.
So should we wrap up?
Thank you very much for this occasion. Okay. And I hope I see you soon.
Yeah, sure. It'll be a great pleasure to have you again. Thank you.
Yes. Yes.